Good evening, everybody, and thank you for joining us in this webinar on the Community Specialist Team for Older People. My name is Lynn Stoddard and I work across Cavan, Donegal, Leitrim, Monaghan and Sligo as the Programme Lead for the Enhanced Community Care. During our webinar this evening, we will cover the Community Specialist Team for Older People, including the role of the Community Specialist Team, also known as ICPOP, referral to the service and the pathways in place. I'm joined here in the Sligo Hub in Woodhaven by Head of Service Frank Morrison, Dr. John Butler, Consultant Geriatrician for Integration for Older People across Sligo, Leitrim, West Cavan and South Donegal, Dr. Conor Mitchell, who is the GP with Sligo South Donegal Network and also a GP in Baby Family Practice in Ballyshannon. We have our three operational leads, Claire McAleer, Donegal, Melissa Currid, Sligo and Agnes McManus for their Cavan team. Also Orla Gilchrist, who was instrumental in organising the webinar this evening, who works with me in the ECC office. So just some housekeeping, the webinar this evening is being recorded and links, resources will be circulated afterwards. You will also have received links to ICPOP webinars and we invite you to, and we invite you to watch those in time. For smooth running of the webinar, all attendees are muted. However, please feel free to add any comments and questions into the chat function. And also we're having a question and answer session at the end. I will now hand over to Frank Morrison, our Head of Service for Older Persons, who's been instrumental in the development of our services across the region.
Thanks very much, Lynn. Good evening, everybody, and welcome to our webinar. From the start, I wish to confirm that I believe that integrated care as provided by the ICPOP team is truly the way forward for the older person who requires assistance with their health and social care. The programme allows us to focus on the patient experience, the outcomes and quality of care. As we are all apprentice older people, none of us want to leave our home, our friends and our families. We need to have the social care and health service tailored to meet the needs of the older person. We all need to have alternatives to residential care, and that is care in the community. My job as Head of Older Persons in CHCDLMS is to put the older person first and to make the older person matter. I strongly believe that the ICPOP team and all the highly skilled staff who work within each team will make a difference. That is, to answer the needs of the older person, to preserve independence where possible, and as identified in the Stauncher Care programme, to provide care in the right place at the right time and as close to home as possible. The teams are in place to assist the older person to achieve health and social care outcomes that are important to the older person's well-being. So we're here this evening to learn about the pathways in place in our three community specialist teams. Our Donegal team is led by Claire McAleer, who we'll all meet later. Our Cavan Monaghan team led by Agnes McManus, who you'll also meet. And our Sligo team led by Melissa Currid, who was a guest speaker as well. On this webinar, we want to demonstrate what can happen and how the service can operate when the whole pathway is open and accessible, what is working well and how the service functions when a consultant is in post to govern and develop the service. Most of our focus this evening is on Sligo service, as it's currently the most developed site. It was a demonstrator site in 2019 and more recently has a full-time consultant geriatrician in post, Dr. Butler, who will present later on. Some pathways are also in place in Donegal and Cavan Monaghan, and these are reported by Dr. Mulpeter and Dr. Miranda in Donegal and Dr. Azam in Cavan Monaghan. Donegal and Cavan Monaghan will progress in line with the Sligo Hub model. Consultant recruitment campaigns are ongoing and we are hopeful these posts will be filled in 2024. So our ICPOP steering groups are in place and in each area to provide governance and to inform and drive forward service development. The membership includes GPs, psych of old age, older person service manager and key clinical staff. Our teams work closely with primary care teams, the chronic disease teams and acute services when considering service changes or developments. There are also very strong links with the community and voluntary sector, such as Alone and Age Friendly Alliance. The three elements of the ICPOP team are falls, frailty and memory. This evening we're focusing on the falls and frailty services that are in place. Under the memory element, the National Model Care for Dementia was published last year. Sligo was fortunate to be a pilot site since 2019, ably led by Professor Jerry McCarthy, Dr. Catherine Dolan and Dr. Bethany Drum. As we are not covering the memory assessment support service in detail this PM, which is for a future webinar, we're showing a short mass service video featuring Dr. Catherine Dole.
Hello, my name is Catherine Dolan. I'm one of the consultant co-leads in the Sligo Memory Assessment and Support Service. I work in conjunction with my colleagues from the acute hospital, community side of things being the mental health and the older person services. We were very proud in Sligo to have this memory service as one of 9 services funded by the HSE under the Extended Community Care Programme to bring timely diagnostic and support services for people with dementia and their carers. So in Sligo we became operational in 2022. This was on a phased basis and we hope to continue developing the service as resource provides. So in this service, we aim to provide a timely assessment and setting up of supports for patients with dementia and their carers. We also, in conjunction with neurology colleagues, have set up a service for diagnosis for under 65. So these are people who have an early onset of dementia. This was previously a major gap in services nationally, and we hope to build on this with an increase in resources over time. So in our team, as I'd mentioned, there is dietitian input. We have some input from occupational therapy and psychology and nursing and medical. And one of the main important features of this service, as I see it, is not just the assessment and diagnosis, it's the key working to provide supports for people on their journey with dementia and their carers, because as we know, every journey is completely different and people have different needs at different times. So this service, since becoming operational in July 2022, has had over 520 referrals of people with dementia, cognitive impairment, along with their family and carers. As I'd mentioned, this service is an integrated service. It's probably one of the first operational services that has integration of clinicians from different areas, including the acute hospital, mental health and older person services. The team, which is a multidisciplinary team, includes occupational therapy clinicians, dietitian, psychology, nursing and medical. And these people work together to provide therapeutic interventions as well as assessment of people with cognitive impairment and dementia. So we're currently open to referrals from secondary care. This includes hospital clinics and mental health clinics, and we hope to open our referrals to GPs on a phased basis once we have the resources to do so.
Okay, thank you for that, Frank. I'm now going to hand over to Dr. John Butler, consultant geriatrician here with the Sligo Community Specialist team.
Hello everyone, and thanks for joining us this evening. So I was delighted to return to the northwest of Ireland here after 25 years in the United Kingdom, based in Wales and Cardiff, where my role was an interface geriatrician. And pretty much the integrated care programme for older people is interface geriatrics in a nutshell here in the northwest, where we work at the interface of both the hospital and the emergency department setting, but also, what I want to talk about particularly this evening, the interface between the primary care setting and the hospital. So this is what it's all about. This is my declaration of interest, I should say. So I'm a proud Leitrim man. So we've got a base here both in Sligo and Leitrim. This is my mum and dad, both living with relative degrees of frailty. And they illustrate the outcome that I think we all want, which is to live well with frailty. So we all have different outcomes and different perspectives that we want, depending on where we work. In the hospital, for example, we're particularly interested in reducing length of stay, reducing bed days, reducing trolley weights. But overall, the collective outcome that I've learned that older people want is to live well at home. And this picture reminds me that's what the aspiration that we all have. And that's what I was delighted to be able to join 2 fantastic multidisciplinary teams, both in the Sligo hospital setting, but also in the community setting here in Sligo and Leitrim. And Melissa will tell us a bit more about what the team does as a whole, but that's essentially what our remit is, to deliver at the interface of both the hospital and community setting. So where do I base myself when I'm working? So pretty much the interface is exactly what it says. There's different settings. So we have a community hospital setting, both St. Patrick's Hospital, Hamilton Hospital, St. John's Hospital. We also have day hospital settings that are, depending on the site as well, developed to different levels. A big part of my work, though, is domiciliary-based CGA, particularly comprehensive geriatric assessment for the most frail patients. So frail older patients who either are unable, or you really have to ask the question, will it make their condition worse if they were to travel? I also do quite a bit of care home medicine, particularly where an older, frailer person's ability to continue living in the care home is challenged. And as I said, a big chunk of my work is based at the interface between the community and hospital setting in the emergency department at Sligo University Hospital. There I work alongside multidisciplinary team colleagues in the frailty intervention team. And I like to think of the emergency department as an extension of the community rather than a hospital service alone. Because a big chunk of what we do in the emergency department is clarifying who needs admission on a clinical basis after we've assessed them and undertaken various diagnostics. So a big chunk of that is, if we do send frail older people home, how do we link up and interface with our colleagues and teams in the community to help maintain that older person at home? That's a big part of what I do, is an integrated approach, working with the intermediate care teams here in the community and with the Sligo CHO area in particular. The other part of my work then is reaching into the Sligo Hospital to outlier wards, particularly where they don't have any geriatrician input, and again helping identify patients who are suitable to be discharged home in as timely a way as possible. In the smaller fund then, I've mentioned unmet need and particularly hospital at home. So we don't have hospital at home service as yet. Hospital at home is targeted at a much higher acuity level of patient, where literally you're providing hospital services that you would normally provide in hospital, moving those out to the community. But that is something that we would like to explore as the service develops over the coming years. Next slide, please. You'll have seen this slide regularly, I'm sure, the ICPOP pyramid service model. I like to describe it as the pyramid of need. So from a frail older person's perspective, your greater need is the higher you are up in that pyramid. So if you end up in hospital, if we're looking at the primary outcome of living well at home, then we really have to work hard to get you back home. And if you're in the emergency department area, in that red zone, that's another area where your ability to live relatively well at home is greatly threatened. And as we all know from lots of work, that the longer you spend in hospital, either as an inpatient bed, but particularly on trolleys, the more deconditioned you come. That's why it's really important to implement comprehensive geriatric assessment in that zone. Looking at the green area then, that's particularly where we are this evening to talk about that interface between those patients you have in primary care who are on the brink or threatened with an acute admission because they may be very frail and have very little physiological reserve or little ability to recover when an insult happens, such as a fall or an acute illness. So particularly from a reaching out perspective, that's an important part of where we try and reach out to prevent admissions by providing timely comprehensive geriatric assessment for that frail cohort of patients who are at higher risk of flirting with the acute hospital setting. I think we just described the pyramid of needs. So I won't dwell on this slide too much because it's busy enough, but I just want to emphasise point number one about establishing governance structures. Melissa will talk a little bit more about governance from an operational perspective, but just to remind us all that clinically, the best way to understand where the clinic governance lies is where the patient is sleeping. Now, it gets a bit blurred when you introduce services like hospital at home, where you're looking after higher acuity patients, but from a clinical governance perspective, patient will remain with the GP and out of hours services when they're sleeping in their own bed, and obviously when they move to an ambulance or into an emergency department setting, the ownership of the patient changes. Next slide, please. So, brief reminder of the clinical frailty score, the Rockwood score, just to again emphasise that we're particularly interested in the severe frail patients, but also all patients really from a score of 4 to 9. We have lots of patients who have varying degrees of frailty, and generally speaking, depending on what happens to you, whether it's a medical insult or a fall, that can really threaten your independence and your ability to live well at home. That's why I like to describe this talk as acute exacerbations of frailty, because as clinicians we're very used to acute exacerbations of other chronic diseases like heart failure or COPD, and it's a useful approach to try and describe if someone does have an acute exacerbation of frailty, how might they best be managed, where might they best be managed, and what's the best way to get timely and effective comprehensive geriatric assessment in so that their needs can be established and met. So comprehensive geriatric assessment, again, as a reminder, it's a holistic assessment encompassing all aspects of a frail older person's needs, including their medical needs, their functional needs, and importantly, their psychosocial needs as well. So, as I say, in the Northwest that I've come back to, I've been really fortunate to work with fabulous multidisciplinary team colleagues working across all the different sub-professional groups who deliver this operation in as seamless and a joined-up way as possible. And the key thing really about comprehensive geriatric assessment is that it's timely and that it generates a plan and that you can execute that plan. So it's not all about the assessment, it's about getting a plan in place to address the various problems that you identify as a result of a thorough assessment. So in terms of pre-hospital comprehensive geriatric assessment, often politicians may talk about, yes, it's very important to do this to avoid acute hospital admissions. So just to emphasise that sometimes, in fact a lot of the time, it is important that a patient is referred to the emergency department, particularly when there's diagnostic uncertainty and particularly when you're not entirely sure if there are things to be gained in the hospital setting that might not be achievable in the community setting. So the evidence base for comprehensive geriatric assessments, as a result, is largely hospital-based and emergency department-based, but increasingly it's becoming more community-based. And that's because, as I say, interface geriatrics is a relatively new specialty, and generating the evidence for comprehensive geriatric assessment is a process that we're building on. But what we do know is that very frail patients, particularly those who are housebound, bedbound, chairbound, do not do very well when they're transferred to the acute hospital setting. So it's a big, big decision to move someone who's very frail from their home to the hospital setting, particularly in terms of what outcomes that we're hoping to achieve. And as I say, leaving home can make things considerably worse in certain cases, and that's why we try and bring as much of the CGA assessment out to our patients in the community where that need is identified and where we can do it in a timely way. So, from the perspective of an integrated care / interface geriatrician and helping with exacerbations of frailty in the community, these are the sort of referrals that I'd be delighted to receive from GP colleagues in terms of the frail cohort of patients that you're worried about. So these are patients who are clinically not needing or indeed not wanting an emergency department referral, and you're still quite worried about them from a clinical perspective. Also particularly interested where there's complexity. As you know, frailty by definition is an accumulation of impairments, and very often there's multipathology going on and lots of various things that potentially might interact with each other. So complexity is one of the things I'm very keen to get involved in as well. These two, a challenging family dynamic and a complex mental capacity assessment, often run hand in hand, where you've a frail older patient who may be cognitively impaired. And whilst we're not talking about memory services per se, a big chunk of what we do, particularly on a domiciliary-based basis, incorporates new diagnosis of dementia, working very closely with our colleagues in the mass service, and also helping to problem solve the problems that are generated by cognitive impairment, particularly in the context of increasing frailty. I also do quite a bit of care home medicine, and I work very closely alongside one of our clinical nurse specialist colleagues who goes into our care home, particularly for patients who end up in the emergency department or come into hospital with a transient acute exacerbation of frailty. And we try and work with our partners in the care home setting and with GP colleagues as well to try and re-establish frail older people back in their care homes and perhaps revisit things like ceilings of care and advanced care planning decisions that might need to be made as a result. Sometimes you'll also need me then for second opinions or for ceiling of care decisions, again where there may be diagnostic uncertainty or where there may be conflicts of opinion in terms of what the next course of action should be for a frail older person. And then as a reminder then, when I'm working, I do both domiciliary and clinic-based services. So we've got a thriving clinic setting here in Woodhaven, Strandhill and Sligo, and we've just started a satellite service based in St Patrick's Hospital in Carrick-on-Shannon. And I was delighted to attend the opening of the Ballyshannon new hospital as well a couple of weeks ago. And I'm sure that we will be looking, and it's been mentioned earlier about when resources allow, but I would hope that we can get to that point sooner rather than later in providing similar service for our frail older patients in South Donegal and indeed West Cavan. Thank you.
Okay, thank you very much, Dr. Butler. And then I hand over to Dr. Mitchell, just from a GP perspective. Thank you.
No problem. Thanks very much, and thanks very much for Lynn for inviting me to this meeting and to be able to share kind of my role at the moment. So I'm the GP lead for the Community Healthcare Network. If you can imagine, the Community Healthcare Network is one of the three spokes of the Enhanced Community Care, along with the CDM Hub and the ICPOP teams. So within the Community Healthcare Network, the GP lead is the conduit between the network manager and GPs. Part of our remit is to roll out the network clinical team meetings, and this will be coming to an area what's called very soon, especially I'm kind of speaking for the Sligo areas now. Currently, we are running in South Donegal and in North Sligo, and we plan to roll out into the rest of Sligo later on this year. So what is a what is a network clinical team meeting? So generally it involves an older person in the community who's defined as complex, and the definition we have for complex is one or more long-term conditions being managed in primary and community healthcare, and the requirement for referral to the meeting is that it requires intervention of 2 or more therapists. So the patient starts their journey on the left, and they may come and see the GP in their practice. They may see one of the healthcare professionals as well. That referral then is made to the community healthcare network manager for this area, would be John O'Hore. And then once a month there's a clinical team meeting that's held, in which the various different specialties that are felt are required are invited to partake in that meeting. The outcomes of that meeting then can be quite varied, but for the discussion at tonight's event is one of the things is we may onward refer to then our ICPOP colleagues as well. And we're also happy to receive patients the opposite way as well. And what that allows us is to be able to deal with these specialised patients within a community setting, closer to their homes, closer to the clinicians that more than likely know them well, and to be able to implement fast and timely interventions for them. And some of the things that can take is to what's called refer to OT, PT, and social work, and to make those patients priority for those specialists. So that's kind of how the clinical team meetings link into our ICTOP services at present. We hope to work with Dr. Butler extensively over the next while, especially in Ballyshannon, to be able to roll out that service for our patients. Anecdotally, the clinical team meetings are working really well in the 2 areas that we've set up so far, but it is a struggle, especially in the times at the moment, to be able to get these up into the other areas, but they are coming. It's just taking a little bit of extra time. And you'll be thankful that that's really all my slides for tonight, so without further ado.
That's great. Thank you very much, Conor. Good to get the GP perspective on that. I'm now going to introduce Agnes McManus, the operation lead for Cavan Monaghan, who's just going to talk about referring to the specialist team.
Okay, thank you very much, Lynn. So thank you very much for having me here tonight. My name, as Lynn said, is Agnes McManus, and I'm the interim operational lead for Cavan Monaghan ICPOP. And I suppose tonight we're very much focusing on our falls and frailty service that we have in Cavan Monaghan, which is that we also have a mass team down there and the memory technology and resource room, very much part of our processes down there in Cavan Monaghan. So from a fraud and frailty point of view, to be referred to that service, we're accepting referrals from our GP colleagues, and that's via the ECC ICPOP referral and the health link, and that's been up and running since last August, and it's been working very well. The referrals are coming in, and obviously the 3 drop-down boxes there are falls, frailty and cognition. You know, you don't have to have all 3, you don't have 2, you can have 1, or you can have all 3. It doesn't really matter for us, but once the service, the need is there, we will accept the referral. And the pathway for our local CST team in Cavan Monaghan from a falls point of view is like obviously that you need 2 of the disciplines that are on our team. So disciplines on our team are occupational therapy and therapy assistance, physiotherapy and physiotherapy assistance, speech and language therapy, dietitian, social work and nursing. Our falls team was set up last year with OT and physio and their assistants coming in. But what we found, like the fall patient is frail and the frail patient may be a faller, and the need for that combined MDT approach. So whilst there wasn't the full MDT with them, you know, those patients were identified as having other needs. So the service as a whole took on those patients to ensure they had the best approach to their presenting illness when they came to us. We also accept referrals from our PHN colleagues, from our HCPOP colleagues out in primary care, with care network managers. Fit team in ED in Cavan General Hospital are a good source of referrals, and then they're prioritised for bringing back out, so it could stop an admission, it could be detrimental to that older person. We also have our links in, as Frank said earlier on, with Dr. Azam. Dr. Azam is our clinical lead at the moment, and we do follow up with him from his gerontology clinic as required. And then we have links with Dr. Abdullah, his consultant neurologist, who works through the cognitive and movement disorder clinic in Cavan. And this will be a lot of maybe movement disorder patients and cognitive patients that will be referred to our service that need that MDT approach for getting to the, assisting them on their journey. We also had take from inpatient reablement beds in the Starn. So if the reablement team in the Starn seeing that a patient is doing well, but maybe that transition to home maybe is slightly a bit more difficult for them, but then they refer them on to us and we help to transition them home, continue that reablement piece and build their confidence in their own home, and that's working particularly well for us. From a falls and frailty point of view, from a falls service, and it's the same for frailty, is that if you are, once you meet the criteria and you've been accepted to the service, we do then a comprehensive geriatric assessment on everybody. And this assessment then will determine the needs of the patient, so it'll hone down what disciplines do they need, and it really then develops their plan of care within the service. So this is very much like an interdisciplinary approach to the patient and their care needs at that time. And this can be very much functional assessments, but it can also be like more support in and around social work and things like that to maybe develop plans of care for future planning for that patient. The big thing is that, obviously, as we've already said, is that it's 2 disciplines. So once they require 2 disciplines, they'll be accepted to our service. From a reablement point of view, the falls patient, they have functional assessment where their 4 outcome measurements are looked at, like their time up and go, things like that. So if they score 1 to 4 on that, they will be directed to our local falls classes. But if they score 5 to 6 on that, then it would be 1-to-1 sessions in their own homes, and that's where their reablement needs are met in their own home. But also equally, if they cannot have access to transport or they are unable to get to classes, then maybe the 1-to-1 reablement would be used at home. And then obviously frailty isn't so much from an assessment point of view, it's more seeing, have they got the potential to engage, are they able to have the carryover to continue. So that would be very much from a reablement point of view. From colleagues on the ground, if you're thinking about reablement referral, I suppose very much have a discussion, identify the goals that you see that would be beneficial to this patient, and then that would help us consider them for reablement. The unfortunate thing just at the moment, reablement services would be a little bit not as responsive as it usually would be, and that would be just due to the fact that that our OT numbers are just depleted at the minute. Let's move on to the next one now. From, as Dr. Butler so rightly said, clinical frailty score is really, the cornerstone of an awful lot of what we do, and the classification of the CFS on a referral coming into us really assists the team in prioritising our caseload to focus the service where the need is greatest. A quality improvement initiative was done a couple of years ago in Cavan between the top team and our colleagues in ED to put in a traffic light system, and this really helps hold down on the referrals coming in. So we really do encourage the CFS score on our referrals coming in, because it absolutely helps us prioritise where we need to be, because, if somebody's hitting the 6, 7 days, they need to be assessed, because you could stop an admission maybe if we were able to manage them at home, and, it would lead to hospital avoidance. And then next slide, please. Just going on from that, just to able to maybe gain more knowledge. I know we're all in the room and in our teams, the clinical frailty scale is very much part of our bread and butter. But this is a programme that's brilliant, and the aim of the programme is to provide healthcare professionals with an enhanced understanding of frailty and frailty assessments. And this is run through the HSE and supported by the CNME. And in each of our areas, it's very much these education sessions are rolled out. In Cavan Monaghan, we and the Cavan Monaghan ICPOP team, we have 5 facilitators within the team that goes out with their acute colleagues and primary care colleagues to deliver these programmes. The programmes can be done in a one-day event or can be done in standalone modules on HSC land. So, you know, it's a great opportunity just to be able to look at the 8 areas of the frailty that as part of the modules. And these are the training dates that we've already completed this year in Cavan and what's coming up, and the same can be said for the other areas in Sligo, Leitrim and Donegal. And I suppose very much at the end, I'd like to say that this is very much the referral processes for us that I've discussed here tonight, and the pathways to us is very much based on Cavan Monaghan, and each of the areas are very different, and we hope to be very much like the Sligo model in the not too distant future when we get the instruction. So thank you very much.
That's great. Thank you very much, Agnes, for that overview of the service in the Cavan Monaghan area. So now I'll hand over to Melissa. It's fair to say that the team in Sligo is more developed than the other areas. We were a demonstrator site a few years ago, so it's well established. So this will give a good insight to everybody on what can be achieved and what we're aiming for across the whole area. So I'll hand over to you, Melissa.
Thanks, Lynn. Good evening, everybody. I'm just going to give you an overview of the ICPOP CST for Sligo, Leitrim, South Donegal and West Cavan. As Lynn mentioned there, we're quite an established team. We are an integrated service that aims to support people over the age of 65 to remain in their own homes as well as possible for as long as possible. Within the catchment area, there's a population of approximately 114,000, with just over 22,000 of those being over the age of 65. And the next slide actually depicts how the population is dispersed. As you can see there, the highest population over 65, Sligo, followed by Leitrim, South Donegal and West Cavan. The ICPOP CST ambulatory hub is located in Woodhaven on the First Sea Road in Sligo. We have a spoke team, as Dr. Butler mentioned, located in St Patrick's Hospital in Carrick-on-Shannon in County Leitrim. And referred patients into our service will be asked to attend one of these locations, as we have clinic facilities in both, or if required, they will be visited in their own home. Our teams consist of various disciplines, which, as you can see from this slide, it's quite an extensive list of disciplines. Many of them specialise in the area of frailty and falls prevention and memory, which has already been outlined by Dr. Dolan in the video shown earlier. We work closely with the acute hospital FIT team and the inpatient specialist teams also, community services and voluntary groups across Sligo, Leitrim, South Donegal, West Cavan, in order to build a network of support and care for the older person and their family in their own locality. The ICPOP frailty and falls prevention teams aim to help people manage better at home and prevent a hospital admission. We also support a return home after a stay in hospital. And our focus is on older people who are experiencing difficulties managing at home, and as Dr. Butler alluded to earlier, this may be due to a recent illness, disability or increasing frailty. The Sligo ICPOP CST falls prevention team offer this focused time-limited service which can last between 6 to 8 weeks or less. We will take a comprehensive geriatric assessment in order to devise a coordinated care plan and a delivery of care which suits the individual. This can include input from the physiotherapy specialist, the occupational therapist, speech and language therapy, dietetics, nursing and case management, ultimately leading to better health outcomes for the older person. Now, the referral criteria includes, for our service in Sligo Leitrim catchment area, that the person obviously is over 65 with complex care needs, typically scoring between 3 to 6 on the Rockwood Clinical Frailty scale. But as Dr. Butler said earlier, often we can accept the frailer patient. They must require input from 2 or more disciplines working on the ICPOP frailty and falls teams, and they must consent to engage with a therapy programme. As you can see there on the list, we have some disciplines who are specialists in the area of falls prevention, And whilst falls prevention is a dedicated service within the ICPOP CST in Sligo Leitrim, it consists of a clinical nurse specialist, senior physiotherapist, which unfortunately is currently vacant, a senior OT, and they specialise in the area of falls prevention and bone health. Now, we've had to make some changes to the referral pathway in this aspect of the service due to increased demand, but also in order to deliver a more effective and streamlined service, which will prevent duplication of services where possible. Falls referrals will now be graded as Tier 1 or Tier 2. Typically, Tier 1 clients require that more responsive interdisciplinary assessment intervention. And as a result, the referral criteria is, as I just mentioned, for the frailty team. Thus, these clients would be captured by the frailty and combined falls team. The aim of the service to be provided to clinics who are clients who are graded as Tier 2 is to identify falls risk, educate on prevention and bone health, and maximise functional independence. These clients will be captured by the specific falls prevention team. The referral criteria for clients graded as Tier 2 is slightly different and includes that they have a history of falls, are at risk or are worried about falling. They must be medically stable and able to follow simple instruction, and they can have a Rockwood clinical frailty score between 1 and 4. Another aspect of our ICPOP service here in the Sligo Leitrim catchment area is the Advanced Nurse Practitioner-led Frailty Clinic, which focuses on the provision of advanced nursing care to the frail older adult. The MPs on our team conduct nurse-led clinics in the ambulatory hub here in Woodhaven. Now, this has been available to GPs across the Sligo town area since September 2023 as a pilot, and it is planned to roll this out to all GPs across the catchment area on a phased basis from Q4 this year, with satellite clinics located accordingly. We're going to start with Ballyshannon and South Donegal. You'll be glad to hear, Conor. And this will be followed by other areas where we are currently scoping out suitable locations. So who can refer to our service? GPs can refer via HealthLink directly or following discussion at the clinical team meeting. Older people who have a home address within the catchment area and who meet the referral criteria. As the service develops, there will be other referral pathways explored, for example, a tailored referral pathway from the National Ambulance Service. Referrals are also accepted from Frailty at the Front Door team, the inpatient specialist geriatric team and the geriatrician OPD clinics in Sligo University Hospital. Our referrals opened up to accepting direct referrals from GPs in August 2023, and this has been a very positive step, offering a single point of referral to the specialist teams, thus allowing for a more streamlined and seamless access to the services we offer. So the process involves we receive your referral via the HealthLink portal or via email, which is monitored twice daily by the team. A team member will screen the referral for suitability to triage, and triaging is carried out weekly on Wednesdays for Leitrim and Thursdays for Sligo. The referral will then be accepted or declined, and the outcome will be communicated via HealthLink or email. Additional information may be needed from time to time from the GP or the wider PCT or acute hospital team referring. We may also request the GP to undertake further tests to inform the assessment. A request for additional information or testing will be sent via the GP practice email, or a member of the ICPOP team may contact you directly. Now, we aim to see clients referred within 2 weeks of referral, but it's often much sooner than this. For example, Frailty at the Front Door referrals and referrals deemed as urgent on triage will be prioritised, with the client often seen within a few days. I suppose it's important to note that as the ICPOP specialist community team interventions are intended to be focused and time limited, with 6 to 8 weeks or less, and that is to support the GP to care for the patient in the community using a shared governance approach. The aim is then to optimise the patient condition and discharge back under the care of the GP, and this will take place as soon as possible. And a discharge summary will be sent to the referring GP once the client has been discharged from the ICPOP service. The next slide gives you just a snapshot, I suppose, of some of the activity and outputs of the ICPOP CST for the Sligo-Leitrim catchment area. And these are from January 2023 to date. And as you can see, we average on 120 referrals per month, and that's across three teams. We've accepted over 1,900 referrals, and year to date, we've 423 referrals accepted. Year to date, we've 331 CGAs completed. We've 10,500 patient contacts for 2023, 2,000 year to date. And 50% of our referrals into 2023 had a clinical frailty score of 5 to 9. I suppose with regard to admission avoidance, 80 referrals from the frailty at the front door team received in 2023. It's estimated that 544 bed days were saved because of ICPOP intervention as a result. To date, and I know this is rising weekly, we have 110 direct GP HealthLink referrals, and that's since August 2023 when we went live. And I suppose 66% of our patients who've had an ICTOP intervention, been under the care of the team, have been discharged home or remained at home as a result. And that's it. Thank you very much. I'll hand you back to Lynn.
Thank you very much, Melissa. So it's great to see the stats there demonstrating the benefits of the service, and certainly that's what we're aspiring to across the full area. So now I'll hand over to Claire McAleer, who's just going to talk about the service integration and also give an insight into where we're at in Donegal as well. Thank you, Claire.
Thanks, Lynn. Good evening, everybody. So rather than repeat a lot of what has been said, because I think Agnes and Melissa have covered an awful lot, I'm going to focus firstly on the model of care for older person services and for the chronic disease hubs. If you just go to the next slide. So really this is what is available to all older people, and it spans from the hospital where they may access the frailty at the front door service or be admitted to bespoke specialist pathways. Below that you will see the clinical specialist team sitting. That's not because that's where we work, but I suppose it's around maybe the complexity of some of what we're doing. You can see the linkages to the community healthcare networks, which Conor referenced earlier. But the key aim is about moving the service from the right hand side of that slide towards the left hand to support older people to live well at home. And I think that has been very much demonstrated throughout the evening as the teams have talked and the consultant and the GP have talked about where things are currently in the service. So really the ICTOP teams are about looking at that model of care. It's about supporting early discharge from hospital, but also really with a focus on maximising the health and well-being by reducing or reversible elements of frailty where possible, or reducing the risk of falls. So it's important, one of the key factors that is really important when we're looking at services like this is the co-design of pathways. So it's very clear from that model that none of us work in isolation. Integration is, while it's called the integrated care team of older people, there's integration within the team, but there's also integration within all the services. So the map to your left highlights what services are available in CHO1 or CHCDLMS. As you will see, focusing on Donegal at the minute, the fall service is provided county-wide, and the frailty service, the ICTOP service, is provided to 2 networks. And very much tonight you'll have heard people talk about the service development based on what your current resources are. So within Donegal at the minute, we are probably the least developed, while our ICTOP team would be considered at 75% maturity. Some of the key posts missing are that of the consultant geriatrician, the registrar and the speech and language therapist. We also work out of an administrative hub and don't have a clinical setting to deliver any services at present. So our service is very much domiciliary based, and therefore it's probably much more labour intensive in ways. And the volume of patients we see in the two networks is manageable with the resources we have, but to extend that to the other two networks would really dilute the service. So for now, we are currently focused on the North and the East network. We do have a falls team. It's a small falls team comprising physio, OT and clinical nurse specialists, and they provide a combination of domiciliary and clinic-based services, and also provide strength and balance classes within the networks. There is quite a long waiting list for the falls service, and that's, I suppose, one of the challenges of providing the service to a large county with a very small team. To counteract that a little bit, we try and manage our referrals in-house. So we have a combination, like the other services. Patients are referred to falls or frailty, but they may not necessarily remain under the falls service. So they're triaged by the falls team and often deemed to be more appropriate for the integrated care team. We have two care needs facilitators as part of our team. And since they've come on board, we've been able to see the majority of patients within 2 weeks within the community specialist service. The team at the minute comprises of 2 candidate advanced nurse practitioners, a clinical nurse specialist, an OT, a physio, a dietitian, a social worker and therapy assistants. We average caseload of about 50 people, which is quite intensive work over a large geographical area. We haven't really touched on patient outcomes, so there are lots of KPIs that we measure, but one of the most important ones for me is the EQ5D5L, which is really about the patient, how they feel. It's a subjective assessment of the patient's well-being, and it's measured as patients enter the service and also as they leave the service. So it focuses on 5 key elements, and it is really a quality of life assessment. It looks at self-assessment of mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. And the individual records their score, as I say, when they enter the service and when they leave. And the majority of cases we see an improvement in their EQ5D5L over the period of the time that ICPOP are involved. Unlike the other 2 services, a lot of our patients end up in the service for longer than 6 to 8 weeks, and that again is due to the domiciliary nature of the service we're providing. So we have 1 physio and 1 OT in the service, and because of the nature of the programs they provide, where they actually maybe do an intensive 6 weeks with each individual, 2 to 6 depending, it means that the patients remain in our service slightly longer than some of the other services. So I'm just going to move on to the next slide that really focuses on integration. So one of the biggest challenges when you're setting up a new services is to figure out where you fit, where the gaps are, who you really need to engage with to ensure that you provide the best possible service with the resources that you currently have. So in the absence of a consultant, one of the key factors for our service was that we had very close working relationships with the acute hospital. So in order to progress the candidate advanced nurse practitioners to become registered advanced nurse practitioners, we work very closely with the geriatricians in Letterkenny University Hospital. They have provided the governance, the training, the support for the candidate ANPs, who both, I'm delighted to say, have completed their academic and been signed off from a clinical perspective and are waiting their final results with a view to registering in October of 2024. That will enable us actually to provide additional resources and additional services such as advanced nurse practitioner-led services. And in order to do that, we will continue to work closely with the geriatricians. We actually meet with the geriatric services in the hospital every 6 weeks to review our pathways, to look at new pathways as more services come on board. So for example, when a physio joined the team, the pathways changed so that everybody's aware of what's going on and that we're not duplicating. We do have 2 advanced nurse practitioners for older person services based in the acute hospital, and it's now really working on pathways to integrate them with the community specialist teams. One of the key things, challenges I suppose around these integrated posts is the sharing of information, and that's very much a work in process by having IT systems that can interface so that we can share knowledge, learning results and resources. So at present we have access to IPMS and ICM, which is great. It gives the team really valuable information when they're going out to undertake CGAs and also when they're planning the care. As well as CGAs, a proportion of our patients receive an inter-eye care needs assessment, which is not a CGA but is a very broad assessment of needs. We'll probably talk about it a little bit later on and go into a wee bit more detail on what it is, so I'll not focus on it so much for now. Following training and education, it is accessible by any member of a multidisciplinary team. So at present we are really focused on the hospitals accessing this service, because this is where we add our comprehensive geriatric assessments and also use this as a baseline assessment that helps us identify the needs of the older person at home. We also participate in integrated discharge rounds, and as you know, the focus in the acute hospital is very much on effecting safe discharges, and a recent development sort of within the last 6 months has been a weekly integrated discharge round, which really allows the multidisciplinary team in the hospital, particularly the discharge team. There's involvement from primary care, older person services, as well as ICPOP residential services and home support. And this allows everybody to discuss the needs of those who are awaiting discharge from the hospital and identify the most appropriate discharge supports required going forward. It's quite a really innovative way of working, and often patients maybe who have not been identified in the hospital as being suitable for ICPOP are identified at that point, and that can change the trajectory of their discharge plan and also their ability to remain safely at home on discharge. Other services that we integrate with are very much the primary care services. Currently the community healthcare network managers, the operational leads for ICPOP and the CDM, and the heads of discipline within Donegal meet on a monthly basis, and that has been crucial for ensuring governance of all staff within the service. As you can imagine, as a multidisciplinary team, you have clinical responsibility for the team working under you, and you also have operational responsibility. But just to ensure that each discipline is working within their scope of practice and working safely, it's very much a joint management approach to the team. So, for example, the physiotherapists will, from a clinical perspective, report into their head of discipline, but from an operational perspective will very much be guided by myself as the operational lead. Other ways that we've linked in within primary care, Conor had mentioned earlier the clinical team meetings. The ICPOP team with the care needs facilitators work very closely with the most established network clinical team in Donegal, which is a NICE network, and have provided inter-eye assessments, which is a really broad based assessment, as I said, for those clinical team meetings, and it has really assisted in getting in under the bonnet of some of those very complex cases in the community that are being managed very much by the primary care teams. And like Conor said, it's a two-way street. we can refer in. We can also participate if we are engaged with a person who is being discussed at a clinical team meeting, and therefore we can look at how we best provide the service to that person going forward. And because ICPOP is very much a time limited service, the care obviously ends up back with the GP and the primary care services, so that interface is hugely important, and it's one that will continue to develop as time goes on. We also look at sort of the services within the community, and those services that are available to the home, and looking at things living well at home. We have trained all our staff to make every contact count. We link with services such as healthy, age-friendly homes. We have a community connector in our team, which is a very unique resource to only 9 of the ICPOP teams in the country. And their role is very much the social prescriber. So when the team are almost nearing completion, the community connector becomes increasingly involved in working towards engaging older people back into their communities again. I think we all know that social isolation is a huge problem for older people, and probably has been exacerbated since COVID. So that role is in development, but is probably hasn't been fully evaluated yet. But there is a sense that it is something that may be mainstreamed in the future. We link with lots of organisations in the community, but one that we probably link with the most is the Alone service, and they really provide a wraparound service to people in the community. They support them through providing lots of coordinated services to facilitate aging at home, and very much are guided by the same aims and principles of the integrated care teams. They support people to apply for grants. They provide befriending services. They support and advise on technology, tailoring it very much to the needs of the individual. And I suppose technology is becoming more and more used within older people's services, and there's a huge variation of what's available, from simple things like Alexas who remind people to take their drugs, to pan watches that monitor people's mobility, that can work inside and outside the home. So if somebody who's confused or at risk of falls has an untoward event outside the home, that then can alert the appropriate person to reduce the risk of those maybe who previously would have struggled to remain at home. We also have a CNS in nursing home outreach, and Melissa sort of alluded to that role before, and again that's very much about trying to bring services into our community nursing units, but more specifically in Donegal to the private nursing homes. The outreach CNS receives referrals directly from the nursing home, where they feel they just need that specialist support, maybe with more complex cases in the nursing homes. The governance, obviously, from a clinical perspective, remains with the GP, but the CNS provides a huge amount of education and support to the nursing homes, and the referrals tend to come, as I say, directly from the nursing homes, but also she case finds. So she'll go into the emergency department and into the inpatient wards on a weekly basis, identify patients who've been in hospital and follow them up afterwards. So again, it's a county-wide service. She averages 30 direct contacts a month, where she sees the patient face to face, and about 60 indirect contacts, and that can be anything from liaison with a GP or a family member or anything else that will help support the older person in the nursing home. So what next for Donegal? Well, we need to secure accommodation, and that's in the process. Like Agnes, we need to recruit a geriatrician, and again there is a huge focus on that at the minute, I'm delighted to say. And we need to scope out to the role of the ANP, and as we sit here tonight, my 2 candidate ANPs are actually at the GP network event for the East Network explaining really about the service and how they would like to develop their service, but really how they want to develop it in conjunction with the GPs, identifying what they need, not just what we perceive to be the problems within the integrated care team. And finally, I would just like to introduce a wonderful lady who availed of our service in the past. Pat Floyd is an inspiration to anybody who listens to her. And for those of you who are Finn Harps supporters, you may actually know Pat because she runs the shop at the Finn Harps football ground. So we'll just roll that.
My name is Pat Floyd and I'm a user of the ICPOP service. I came out of hospital in May 1921 and couldn't walk and was told I would never walk unaided again. When I was leaving hospital, the hospital referred me to the ICPOP team and they took over from there. They came twice every day, got me out of bed and dressed, showered and dressed. And then at dinner time, they did all the physio. And I really felt, oh, please stay away for a day. But they were there and they were so good. I couldn't have done without them. I wouldn't be here today walking on my own if it hadn't been for them. They were brilliant. They did a lot of exercise and they got me that I was able to stand up, and from there I was able to move on a rollator, and finally I was able to walk with their help, and eventually I was walking on my own. But I just wouldn't be here, and I have such a good quality of life now. I am able to go to mass, drive my car, go to my football and go to play cards and different things. My whole lifestyle has changed.
We're just moving on now to the panellists, and Frank is going to chair this, and we just have some questions. We don't have any in the chat, so if you would like to ask any specific questions, please feel free to enter it in the chat, and I'll just hand over to Frank now.
Okay, Lynn, thanks very much, and thanks very much everybody so far. Our first question tonight for the panel is Interrail, and it is, what is it and how can it be used in the future? Which of the panelists would like to share?
I'll answer that. Okay. So the inter-eye assessment has been in use in Donegal and in the other areas actually since probably around the autumn of last year. It is a national IT system that has a really comprehensive assessment of needs on it. It looks at 20 aspects of care, similar to the CGA, but with some elements lacking. But it is very much about looking at the social, psychological, physical, and the well-being of older people. It is currently, it has been undertaken by a team of dedicated staff who are care needs facilitators. And where do I see it at the minute? At the minute, I referenced earlier where we use it similar to a comprehensive geriatric assessment, but not as a replacement. It is a lengthy assessment. It takes approximately an hour and a half, but it provides extremely rich data. It works on algorithms, so while some of the assessments in it are maybe not assessments that you'd be familiar with, the assessment itself produces outcomes and it guides the team very much on how they're going to deliver care and what the key elements of care that are needed to be delivered are. So it's as I say, it's quite a long assessment, but it provides huge data. It's not a document management system, however, you can actually add documents to it. So within the service, one of the things that we would find maybe it lacks that's in the CGA is that it doesn't have a list of the patient's medications. However, the assessors complete that list and just add the documents onto the system. So in some areas they may be adding their CGAs to it or any other documents. So basically, once you've had the training and know how to access the system, you can actually then look at anybody who's had an inter-eye assessment and have access to that information. Where it's going to be used in the future is very much probably around home support and long-term care. It will replace the CSR at some stage. The national team are now, there's a few people dedicated to really working on the rollout of this. But in the interim, we have used it where we find it most appropriate to use it. And, you know, as we talked about the interface and the integration, the clinical teams have found it really useful to have that depth and breadth of information.
Thanks very much, Claire. Very good. Our second question tonight is, what are the benefits of referring older people with mild to moderate frailty? Whichever the...
Yeah, I can take that one.
Thank you.
I suppose with any level of frailty, we're often looking at reversible causes. And as ICPOP adopts this interdisciplinary specialist approach and assessment, we can catch those people early on their frailty journey and address those factors that are contributing to their level of frailty through adopting the comprehensive geriatric assessment, as we've explained earlier, and as John explained during his talk. So yeah, I mean, there's huge benefits of referring those people into our service.
Thanks very much, Wilson.
Anyone to expand on that, John?
Yeah, I suppose, being the devil's advocate, it's good to look at evidence, and the evidence base for comprehensive geriatric assessment is largely hospital based. And having said that, really frail people, particularly those who are severely frail, really benefit from a comprehensive geriatric assessment in their own home. So I suppose it's trying to get the balance right between the overall outcome, which is living well at home. And if you break that down into two parts, it's living well and at home. So there's that competing tension between the integrated care service and pulling people out of the emergency department, out of hospital to get them living well at home, versus, I suppose, the potential risk of inundation with referrals. And then you are snookered to some extent, particularly in the context of constraints. And I mention constraints because we know we are living in a period, and we've heard it across the table, we've heard resources used a few times, particularly when there's an embargo on recruitment at the moment. So it does put pressure. So what I, as a geriatrician, and like us all, we practice evidence-based medicine. The best evidence is supporting people coming out of hospital, but we're particularly interested in any patients from the community-based setting in that green zone who are at risk of decompensating quickly if they have an exacerbation of frailty. And that includes patients who are mildly to moderately frail. The irony is you can be severely frail and be at very little risk of not living well or dying well at home because you've got such good resource built around you, for example, in care homes or where you've got really good family support. The opposite of that is you can be vulnerable or mildly frail, but living alone, and something minor can result in catastrophe. And our GP colleagues are really good at identifying those sort of patients who they can see it would not take much for this lady or gent to have a catastrophe and a long inpatient stay and probably end up living in a care home potentially if we don't intervene in a timely and effective way. And they're the sort of patients that we very much value having referred to the service. And we know you know your patients really well, much better than us, and you're best at identifying them for us. And we're here to help them when they come our way.
Thanks very much. Very good, thorough answer. Dr. Butler and Claire, I might angle this next one at both yourselves. What value do the ICPOP CSTs add for local services and local referrers? Whichever you'd like to take that.
Well, I suppose we talked about the integration earlier, and that integrated piece is key. I think none of us are an island, and we all need to work at providing the best possible service with the resources that we have. So for me, the integrated care team are often offer a wraparound service where they provide that short, sharp intervention, but really focused on the reversible causes of frailty. Don't manage them all. Some we don't succeed with, but having that multidisciplinary team at your disposal to look at the comprehensive geriatric assessment and actually try and address the needs of those frail older people. So for me, the specialist team provides that specialist knowledge, but very much with a view to working hand in hand with our primary care colleagues and our acute care colleagues.
Thank you, Chair.
Thanks, Frank. And briefly from me, there's a cohort of patients who live on either side of the interface between living well at home and deconditioning, dying, and having very poor outcomes in hospital. And the beauty of the ICPOP service, particularly when it works very much in an integrated way with the trade intervention team in the hospital and the in-reaching teams in the hospital setting, is they can really target those patients who have the greatest need. And that's what it's particularly satisfying at working in both a community and an acute hospital base, because the reality is we follow our frail older patients where they go, and that's what they want. They want a seamless service. They don't want it to be handed over from one team to another. And I think that's the key to integration. So it's community work happening in the hospital, and it's hospital work happening in the community, rather than two separate entities that are joined together. And that's the way we try and evolve with integrated care services.
Thank you very much. Anybody else want to add anything? Move on to the next one. We're covering it all, broad spectrum. What are the plans to expand the services? I know we touched on it throughout, but if anybody wants to kind of give it in a succinct manner.
Yeah, I suppose for us in the Sligo-Leitrim catchment area, I did mention during my presentation, we are looking at expanding. We're very conscious of the gaps in our service provision, particularly in the South Donegal area. I suppose at the moment we're under significant challenge with shortage in resources, particularly around our therapy disciplines. And you know, everybody's very well aware that we're in the middle of a moratorium at the moment, so we're prevented in, I suppose, replacing and recruiting any of those vacancies. But we are going to start, as I mentioned earlier, with our ANP-led clinic starting in the Ballyshannon area. We have clinic space identified. I suppose moving on from that, we're very much looking at a business case and our service planning for next year around resources that we need to provide a full ICPOP service in that area. So it's certainly something that's on our radar, and that's something we're working towards. And certainly, you know, integrating with our colleagues in the lovely new Ballyshannon Community Hospital, which is fantastic. And hopefully we'll be running some clinics and geriatrician-led clinics there in the near future.
I must say, if you didn't mention the new hospital, I was certainly going to bring it up with myself, right? Anybody else like anything to add to that?
I suppose for me, we aspire to be what Sligo is now. It requires a huge amount of resources to get there. As a starting point, I would really like to be able to expand the service to the south and west network into Inisho. And unfortunately, you know, we do need some additional resources, but primarily we need the consultant posts filled. And but I think as the two candidate advanced nurse practitioners become registered advanced nurse practitioners, it provides new opportunities, and that's where we're at, sort of scoping out those next steps for the service in Donegal.
From a Cavan Monaghan point of view, absolutely, I'm singing the same hymn sheet as Claire, is that a consultant would help us expand the service that we have. Like, we don't have that in-reach into Cavan General Hospital, and that's something that, as per the model, that should be something that we were looking at. But until we have our consultant in place, that really isn't something that we are able to do. But it's really lovely to come here this evening and listen to Dr. Butler and see what having the consultant in place leads to the service, and it's heading back to Cavan with enthusiasm to hope that that's where we'll be in the not too distant future. And I suppose very much like everybody else at the table, it's about expansion of the service and bringing services out to our local communities. And you know, at the moment, the States is looking at trying to do a piece of work with St Mary's and Castleblaney, that we'll be able to do outreach clinics there, so that that's launch a care model closer to home would be very much, we'll be looking after the Monaghan people in their own county. I suppose the unfortunate thing at the minute, as everybody said, with the moratorium, are we looking at a contraction rather than an expansion at the minute? But hopefully those things will resolve as the years goes on.
That's very good. I hear a lot about moratorium. However, I just need to say that from what I've heard tonight from the three different teams, that there is huge work being done on what we have, and that is, we can see from the stats the difference it's making, and I think it's palpable, and I think we have to keep doing what we're doing in a very good way. A last question so far is, I might ask Dr. Mitchell to answer some of this. Support for referrals, right? How do I access support for decision making in advance of making a referral? What can I do?
I think you have to look at it from 2 points of view. From a PGP point of view, I think it's about building connections within your area. So it's about talking to your public health nurse, it's about talking to your OT, your PT. You know, these are people that you're going to rely on and your patients are relying on day in, day out. There's now a formal meeting going to be set up that you will meet these people on a semi-regular basis as well. So that will formalise it somewhat, but actually most of what we get sorted is in an informal setting. It's the knock on the door, it's the telephone call, and it's to be receptive to that. And you know, these decisions, what's called, can be discussed. You know, and generally my public health nurse will know things, what's called, far in advance of where I ever come into the knowledge with regards to families and with regards to people maybe who are just struggling at home, because they will see patients and they will put on the best of makeup and what's called, they will make sure that the walk from the car is absolutely fantastic. But what's called, at home, these people are struggling. And you know, unless you're looking out for that, you're potentially not seeing it. And then for my healthcare colleagues, it's the same. It's, you know, it's pick up the phone, it's get to know your local GP. And I'd like to say that I hope we're not all cantankerous, overworked GPs, and you know, and that we're receptive to being able to take phone calls from our colleagues, to be able to discuss maybe patients who are in difficulty, who maybe need that little bit of extra help. And that extra help then, what's called, can initiate maybe in the community healthcare network, can go to a complex team meeting, and then potentially, what's called, can go up to ICPOP, what's called, or can bypass that care team meeting and completely and go straight to ICPOP. And that's really what we're looking for, is, you know, that we can get patients for ICPOP is in, seen, back out again, so that service is there for new patients that need the service, and the community healthcare network then is there to aid and help and to facilitate as once that patient has stepped down a little bit.
Thanks very much. Anything else from anybody?
I think from a lead point of view, like if any of our colleagues out there, especially from a Kevin Monaghan point of view, my mobile number is on the slide. So like if you're querying whether you don't know whether to refer or not, log the call, we'll discuss it. I'm very happy to help in any way like that.
Yeah, and we'd all agree with that. I think that's something that we all offer. The numbers are there, lift the phone and ask us if you have any queries. I think just something that we haven't really touched on tonight is carer burnout, and there's a huge amount of that in our communities. So while often, you know, the team may be supporting the older person, there's a huge amount of support required by carers, and it's a very challenging role for many people in our communities, and I think it's something that we just need to be very cognizant of, particularly when we're trying to maybe get people out of hospital into very pressurized situations. So
Thanks very much. So Lynn, I'll hand it back to yourself. Thank you.
Okay, thanks very much, everybody, and thank you to everybody who has attended this evening. We're just finishing up on time, so thank you for staying with us. All the videos will be available on our CHCDLMS YouTube channel, and so they'll be up early next week. And also, all of you that registered will receive the presentation and links to the videos by email in the coming days. So thank you very much, and safe evening to everybody, and safe travel home to everybody that's here, travelling to Donegal and Monaghan, Cavan, Leitrim, everywhere. So thanks very much, everybody, and good night.
Thank you.
Thank you.